This conference will now be recorded.
Okay. Hello, people. Welcome to class. So there has been an update in the herpes guideline, herpes management of herpes simplex in pregnancy and neonate. So because of that, we are doing this class. There, some changes are there, but yeah, it is important to know from the basics. So, like herpes virus, double-stranded DNA virus. There are two types. We already know that. So, herpes simplex 1 and herpes simplex 2. Mostly, like there could be orolabial infections. They are caused by herpes simplex 1. And usually, these infections are acquired during childhood by the physical contact. Genital herpes is STD and most commonly caused by herpes simplex 2. But what is really happening in UK and other countries also, uh, prevalence of genital herpes simplex 1 virus is also increasing. So we are like dealing right now, we are uh, dealing with the genital herpes. So the message for you, that genital herpes can be caused by herpes simplex 1, or it can be caused by herpes simplex like 2. Okay, so both viruses can cause the genital herpes. Now, like what is the etiology? So genital herpes asymptomatic. Many of the times the infection would be asymptomatic. Asymptomatic infection is difficult to quantify. So, until recently, there are serological assays are there that can detect the antibodies through herpes simplex, but they unable to currently accurately distinguish between the antibodies into herpes simplex 1 and herpes simplex 2. But now there have been type specific serological tests. So as the type specific serological tests are there, so even like they can find out whether the antibodies are there to herpes simplex 1 or herpes simplex 2, or even in the asymptomatic infections also, because of the recent developments, type specific serological test, it can be find out. Okay, now according to the current estimate, 70% of the UK population has herpes simplex 1, and 10% of them is positive for the herpes simplex 2. Okay, neonatal herpes, like it can present in various forms. It is rare in UK, but yeah, if it is disseminated infection, then the consequences would be really severe. Now, how it get transmitted, and how, so it is transmitted by the, usually with the contact of the mucosal surfaces, oral genital secretions with herpes lesions. Viral shedding would increase with the active lesion, but can also occur without physical symptom. That is the main worry, because the viral shedding can occur without the active lesions also. Direct contact with the maternal secretions is mostly cause for all neonatal herpes, but postnatal transmission can also occur. Okay, and in the upcoming slide, the guideline denotes even the percentages, how much is the postnatal transmission. Usually in the postnatal period, orolabial herpes occurs. Now, the neonatal infections occur when the primary when there is a maternal infection in third trimester, and it happens within the 6 weeks of delivery. That time, if the baby is delivered, then the transfer of protective antibodies from mother to baby will not be there. So, chances of having neonatal herpes infection, if the mother gets it, the primary infection within the 6 weeks of delivery, the chances of the neonatal herpes simplex infection would be very high. Now, how it got diagnosed? So usually, when the skin to skin contact occurs with infected person, the they would be within in a span of 3 to 7 days. There could be a small blister and the ulcers, Usually they are on the genitals or around the like the anus. First herpes outbreak, when it occurs primarily, usually it is most painful, and it may last longer than the recurrent or the further outbreaks. And usually the ulcer occurs, and these ulcers are painful. Ulcer and blisters are painful, and also like they are bilateral. Apart from this, there could be some associated symptoms, like there could be associated fever, muscle aches and pains, and headaches, vaginal discharge with painful urination. Usually, it causes autonomic neuropathy, involvement of bladder. Because of that, the possibility of having painful urination is very high, or the distension of the bladder the patient usually comes with. They could be associated swollen and tender lymph glands in the groin. They could discharge from the lesion, and the neuropathic symptoms, like I already said, because it affect autonomic neuropathy. There could be urinary retention, or there could be leg pain. It happens because of the inflammation of the ganglia. So when many of the times you would get a question where the patient will come with a painful ulcer, with a dysuria or painful urination or retention of urine, then yes, of course your diagnosis will go towards the herpes simplex. Now, the test. What are the tests available? So it is important to know that two type of test. So number one test is PCR. So basically, with the PCR is a test that detects the genetic makeup or the genetic material of herpes simplex virus. Basically, PCR DNA. Now, from how we get it this test, the swab will be taken from the herpes lesion, the fluid that comes out from the herpes lesion. The swabs are taken and they're sent off to the lab. Then with the DNA PCR they'll be able to detect herpes simplex. Okay, even they can detect herpes simplex 1, herpes simplex 2, even both type of that. It can detect herpes simplex, even the latent stages of infection also. So now when the infection is there, so it is important to understand that the PCR test usually detects the virus. Now we already know, whenever we get any infection in the body, in response to that infection, the body will produce antibodies. So how we get to know whether antibodies are there or not? So herpes antibody blood test is done. Now they look for the antibodies, whether they could antibodies with the herpes simplex virus 1 or herpes simplex virus 2. uh, so this way there are two type of test. Many of the time the people are confused, why PCR and why antibody test. So I'm repeating it again. PCR test is done, that would detect the DNA or the genetic makeup material from the virus, and the sample will be taken from the lesions of the herpes. Okay, and to detect whether the body has developed antibodies or not, there would be blood test to check for antibodies, whether they are for simplex 1 or simplex 2. So that clarification of the test that is necessary for the herpes would be important, because that helps in understanding the guideline. So this is just a simple thing. So first, IgM antibody would be formed. They usually form within 7 to 10 days after infection. They would be elevated after up to 2 weeks. After that, they will go away. Body will clear it off. Usually, we are able to detect the active infections, but the diagnostic significance is less for the IgM antibodies. Okay, apart from this IgG antibody, antibody would come after the initial infection. It can be, we can with the antibodies, like as I said previously, we'll be able to find out whether it is a herpes simplex 1 or 2. But as we are doing it from the blood, so we can't get to know whether these antibodies are in response to the oral lesions or in response to the genital lesions. Is that clear about the testing? Because this I found that a little difficult part. People get confused with it. Is it clear with the testing part?
Yes, ma'am.
Okay. So again the same thing. So diagnosis of of herpes by PCR. So for the detection of HSV. Now previously we used to do culture, viral culture, but now the studies have shown that there is a greater sensitivity of DNA PCR as compared to culture. Antibodies we can get it, and IgM antibody detection is unreliable. Okay, this I have already explained. Now, what can happen? Why we are so worried? What can happen to baby and what can happen to mother? To the baby, there could be neonatal herpes, can be caused by herpes simplex 1 or 2. Infection can be limited to skin, mouth, or it can spread to brain, or disseminated infection could be there. If it is a local disease to skin, eye, or mouth, usually the prognosis is good. And with the antiviral treatment, um, usually the chances of encephalitis or disseminated infections, it becomes less. Neurological morbidity would be higher in local CNS disease. If there is a local CNS disease, then it is higher even with the appropriate treatment. If it is untreated, like it is causing encephalitis, if it is untreated or delayed treatment, then it can affect their intellect, baby's intellect, and also there could be death. Infection with herpes simplex 2 has got poor prognosis as compared to herpes simplex 1. Okay, this is just a briefing. What can happen to neonate? Maybe you can get any question from here. What can happen to mother? Usually, like the the infection will show the similar symptom in the pregnancy as compared to the non-pregnancy state also. Most, like usually it in the pregnancy this condition will occur in second or third trimester. There could be, it can spread also, so there could be encephalitis without hepatic involvement, or hepatitis without central CNS involvement. There could be disseminated skin lesions also. So if it is like liver is involved, then it could be progressive hepatic necrosis. That time the chances, like it can be fatal for the mother. Okay, but in this era it doesn't happen, because usually when the patient had symptom, they come for the treatment. Now this was a little brief about the herpes. Before we move on to the guideline, because the guideline just give us a recommendation, explanation is not there. Now what the guideline says, so guidelines says the same thing, that neonatal herpes, it can be caused by both kind of virus, whether type 1 or type 2. Okay, and this number may be important for part 2 people. Okay, in UK surveillance, 52% of the neonatal herpes were caused by herpes simplex virus 1, and 48% because of the herpes simplex 2. Mode of transmission, so these numbers now it becomes important because these are from the guideline. From direct vaginal in secretions, the uh, like infection occurs, and it occurs in 75 to 85% of the patients. Postnatal acquisition could be there, as I was saying, and the percentage is 10 to 25%. So this may occur as exposure to orolabial or herpes infection from a close person in the vicinity of the child, baby. There could be transplacental spread in case of if the mother is having viremia, and a congenital herpes can occur in 5%. All these three percentages would be important for like part 2 people, and part 3 people should know about the like how it can spread. Now this thing has been added new in the guideline, genital herpes classification. It was not like same in the previous guideline. So now like initial episode, it can be caused by herpes simplex 1 or 2, and like it is dependent whether the individual had prior exposure to other types or not. Now they have divided infection in two parts. Previously, it was only two classification. One was primary infection, second is recurrent. That was easy to remember and we knew it. But what the new guideline says it, now the the infection, initial infection, they have divided into two parts. One is primary infection, another is non-primary infection. Now, what is the difference between primary or non-primary infections? So, primary infection always first, and without any pre-existing antibody of either type. So primary infection is first contact without any antibodies. Now coming to the non-primary infection, what the guideline says. So non-primary infection the is the first infection caused by either of the two viruses, but the pre-existing antibodies are there. And why it happens? According to the new guideline, initial episode sometime may happen in one third of the patient, and like and the patient that will not be recognized initially, or the patient will not show the symptoms. So this happens in one third of the patients, that they had infection but it was not recognized, so they developed antibody. So this kind of people will grouped under non-primary infection. So there are two different parts. I'm repeating it again. Primary infection is the infection, first infection without pre-existing antibodies, and the primary infection is the first infection with pre-existing antibody to the n- uh, either type of the virus. So these are two different things that you should understand. Is it clear?
Yes, ma'am.
Okay, recurrent episode, as we already knew, that it happens because this virus, or usually it remains in the sensory ganglia. Because of that, any of the time when the body immunity is less or any immunocompromise is there, chances of her there could be flare, and that is a recurrent infection. So it happens because of the reactivation of pre-existing herpes simplex 1 or 2 after a period of latency. So now, what are the factor that is associated with the transmission of the neonatal herpes? That would include whether it is a primary, non-primary, or recurrent infection, time of the maternal infection, whether the antibodies, protective antibodies, are there or not, duration of rupture of membrane, mode of delivery, and use of assisted instruments such as vacuum forceps or if we scalp electrodes. So these are the certain factor that will tell whether the transmission of neonatal herpes would occur or not. Okay, the risk of transmission is high when the primary infection is there in third trimester, and particularly within 6 weeks of delivery, as because that time there would be a viral shedding and baby would be born without protective maternal antibodies. And for the neonates, for the preterms, this risk be very high if they are born before 32 to 34 weeks of pregnancy, because in that situation they will not get the protective maternal antibodies. Now, like when the first episode is there, how to manage during pregnancy, what the guideline says. So yeah, this is not very different. So careful history, we have to do the risk assessment. Then the patient has to be reviewed by the obstetrician, patient to be referred to the gum physician, because who will help in confirming or refuting the diagnosis whether yes it is in genital herpes, and the screen for other STDs would be done. DNA PCR would be arranged, and DNA PCR, like it is from ulcers. If so, what the guideline says, from the ulcer, this PCR would be done for herpes simplex type, varicella zoster virus, and Treponema pallidum for syphilis. All of these lesions usually present by with the ulcer as a presenting symptom. So this is new guideline says about that. So PCR will be sent for all these n- pathogens. Apart from this, full STD screening that would include chlamydia, gonorrhea, syphilis, HIV, and depending upon the risk assessment or risk factor, hepatitis B and C. So there are a few changes here that they're doing so much testing from the ulcers. Previously, it was not there. After that, when the patient comes, now what could be the treatment? So treatment is supportive treatment. Supportive treatment would include like paracetamol for pain relief and also like topical lidocaine. Either it could be 2% gel or to 5% ointment, saline bathing, particularly while urinating for symptomatic relief. So these are the supportive treatment when the woman in the pregnancy present with the herpes. What could be the treatment? Treatment these are the same only. So oral acyclovir 400 milligram 3 times daily for 5 days. That is the 435 is the mnemonic. And if the valacyclovir is given orally, it will be 500 milligram 2 times daily for 5 days, or 525 maybe the mnemonic. But if your patient is having severe infection or disseminated herpes simplex, that time IV acyclovir would be given in the doses of 10 milligram per kilogram of body weight. That has to be given 3 times a day depending upon the body weight. Okay, so this is for the IV. Now, and apart from this, the patients who are immunocompromised and the pregnant women may require higher doses. So advice has to be taken from the microbiologist about that. And why we offer antivirals to the patient? the because this will cause reduction in the duration of the disease, and also it will cause decrease in the severity of symptoms, decreases the viral shedding also. Acyclovir and valacyclovir, they are not licensed to be used in pregnancy in UK, but yeah, they are considered safe, and there has been no increased incidence of any birth defects. Some studies that babies can have transient neutropenia, rather, no congenital effect usually happens. But yeah, whenever you are prescribing this to the patients in UK, to your role players in the exam, you have to just say that they are not licensed in the UK. Okay. Now, if the patient has got herpes, then there could when the suppressive doses has to be given. So there had been a changes in the suppressive doses. Why the suppressive doses are given? Because this will decrease asymptomatic viral shedding at the time of delivery, and also lesion at the time of delivery. Also, like, they reduce the chances of premature delivery. These are the doses are the same: 400 milligram acyclovir 3 times a day, and valacyclovir 500 milligram 2 times a day. Now they are starting from 32 weeks of gestation. So this is the change from the previous guideline. Previous guideline, they used to give this suppressive doses from 36 weeks. Now they have changed it to be given to the 32 weeks. So this is a change in the guideline, necessary to be remembered by both part 2 and part 3 people. Apart from this, uh, another thing they have said: if the patient got infection in the third trimester, so it would be convenient to continue, acyclovir or antivirals according to the delivery. Maybe they can start suppression prior to 32 weeks. So sometimes if they give you a question, the 31 or 30 weeks pregnant patient with a primary herpes, in that situation you have to give treatment and you have to continue the suppression. Okay, so these are the changes in the guideline. Apart from this, this is also new thing they have added. Now if so whenever the patient is there with the herpes, and risk assessment has been done for the preterm birth. If it is, there could be possibility of any preterm, then acyclovir in reduced doses. Now you can see it is 2 times daily. Valacyclovir also in reduced dose, the once daily. So when they are starting it before, and it has to be started from 22 weeks of gestation. So apart from this, once the 32 weeks are reached, then the dose would increased. It will be acyclovir 3 times and valacyclovir 2 times. So this change, this is a new thing that has been added in the guideline. It was not there in previous guideline. So we are going to get question from this part, that that what the changes they have made with regards to the preterm delivery. Any scenario, even the part 3 people can get and part 2 people can get in their question, because this is a new change. Is it clear? Any question? Any question? Okay. Now additionally, what they want, like many what is the additional consideration for the first and second trimester acquisition, and when the patient is going to have delivery within 6 weeks of getting the virus. So if the patient, usually they have to know, they need to do herpes simplex serology, because to find out whether it is a primary episode or whether it is a recurrent episode. Apart from this, another advice, this was not there in previous guideline. The patient has to avoid sex in third trimester, including sex with a condom or the oral sex. Why? Because there could be possibility that patient may have antibodies to one type of the virus, but yes, they are prone to get infection from second type of virus. So they want them to avoid sex in first last last trimester, to avoid to get any kind of infection. Apart from this, is already there in the previous guideline, because of the risk of uh, like uh, viral shedding, and the increased risk of chances of transferring this to the virus as high as 41% if the primary herpes occurs within third trimester. Then the recommended mode of delivery is cesarean section. There is no change in it, that you already know, and the percentage of transfer is 41%. This percentage is also same. Now, as I said, when in the third trimester, they are doing when the patient comes in the third trimester and they're having lesion. Now, we have to find out whether it is an initial lesion or the primary lesion or it is a recurrent one, because in 50% of the patient, they will present with the first episode, and usually it would be in recurrent infection. This percentage of the 15% has been added new into this guideline. So what has to be done? Usually DNA PCR will be done from the genital from the genital swabs. So they will detect the type of virus present in the swab. Apart from this, they will do the serology and they will do the blood test. If if they have if they got the herpes simplex 1, for example, from the swab, and same antibody and herpes simplex 1 antibody from the blood serology, then they would confirm it is a recurrent infection. In that situation, mode of delivery, they will it can be vaginal birth. So and uh, anytime when the results are there, then they can make the changes in the plan. But if there had been any confusion or the diagnosis has not been made, whether it is a primary or it is a recurrent, that time initial plan of delivery will be, they will assume that it is the first episode only, so they will not take risk. So if any so if the patient is getting infection in third trimester, they will consider it as the first episode, manage it like that only. But yeah, they will do the swab and the serology from the blood. If it comes out to be the recurrent, then the plan of birth would be changed to vaginal. Okay, many of the students are confused in that, from where to take sample, what to find out. So I think now the things are clear. Okay, so if the swab sh- shows same virus and blood serology shows same virus, then it would be considered as a recurrent infection. Mode of delivery would be vaginal. Okay, so this about the primary herpes. Now, the recurrent herpes, not too much of a change, it is almost the same as in the previous guideline. The patient has to be reviewed by the obstetrician. Risk of transfer during vaginal birth is 0 to 3%. Review by the gum physician, because risk assessment for other STD infection has to be done. The patient to be given suppressive antivirals from 32 weeks, and if there is risk of premature delivery, then they will start it from the 22 weeks. So this is the major change in the guideline, that they have added preterm. If the patient is at a risk of preterm, now they, with the less doses, they will start it from 22 weeks. And once the patient is 32 weeks, then they would increase the dose. Okay, then they would increase the dose. So this is a small change from the previous guideline. Now if the patient, like if the patient comes uh, with a primary herpes at the onset of the labor or within the 4 weeks following birth, in that situation they would careful history, risk assessment, urgent referral to the gum physician and obstetrician, neonatologist. PCR from PCR is taken from the ulcers, herpes simplex serology to be performed, and patient to be guided to be take urgent medical help. This is kind of a scenario when the patient is having lesion at the time of labor or 4 weeks postnatal, because if the patient get infection for 4 weeks postnatal, then also baby is it at very high risk. Now with the primary episode, uh, if the delivery if the primary episode, if the vaginal birth occurs, risk of neonatal herpes is 41%. This is the old number that we know. Now new thing, they have added the non-primary infection also, where I'm repeating the definition of it. It is the infection for the first time, but the patient has got antibodies. Okay, so non-primary infection, if the vaginal delivery occurs with the herpes infection, risk of transfer to the baby would be 25%. Non-primary episode is a new identity in the guideline, and the risk of transfer is 25%. The very you guys can get this question in the exam. Now mode of birth, that we already know, that if the patient gets like primary or non-primary herpes at the time of delivery or within 6 weeks, cesarean section is the preferred mode. And if the rupture of membrane is there, and ideally the cesarean section should be done within 4 hours, but what the research has shown or studies has shown, even if with the rupture of membrane cesarean section has been done more than 4 hours, then also there is a benefit of cesarean section. Now there could be another scenario that the patient has got you know uh, like decline cesarean section in that situation, and she wants vaginal birth. So that would be the high risk case, In that situation, IV acyclovir to be given to the mother, that is the 5 milligram per kilogram 8 hourly, and to the neonate also, to the neonates also, intravenous acyclovir. Now the dose of neonate is high. You can see it is 4 times higher than the mother. 20 milligram per kilogram of body weight 8 hourly. Okay, so mother and the previous mothers and the pregnant women who present with the first episode at the birth or 4 weeks postnatal, or the adults may become unwell without classical herpetic symptoms. The baby born to this in this situation would be managed as a high risk baby, and in this guideline the management for the baby postnatally has depended upon the highest high risk and low risk that I'll be just speaking. Now recurrent herpes vaginal birth can be is a mode of choice. Risk of transfer is 0 to 3%. Vaginal birth can be offered to the patient, but options to be given. They can go ahead with the cesarean section also, but ideally vaginal birth, because risk of transmission is only 0 to 3%. Now, genital herpes, if the patient has got preterm pre-labor rupture of membrane, so what would be the management? There would be multidisciplinary approach in which the obstetrician, neonatologist, and gum physician to be involved. And usually, like if the decision is made for immediate delivery, it would be cesarean section that will remain the first choice, decreasing the risk of neonatal herpes. Apart from this, if the preterm birth is there, and in that situation and the conservative like conservative management is chosen, that time intravenous acyclovir can be given every 8 hours till delivery. Prophylactic steroids can be given, and within 6 weeks of the in primary infection, usually the cesarean section may offer some benefit despite the prolonged rupture of membrane. Okay, so some they may give you scenario for the management of the preterm pre-labor rupture of membrane, and the patient has present with the lesions. So this is very simple now. Multidisciplinary approach, conservative management, steroids, IV acyclovir every 8 hours till delivery, and possibly cesarean section. Now, if the patient comes with a recurrent herpes and the preterm rupture of membrane, in that situation they will offer her they will consider giving her oral acyclovir suppressive doses till the delivery. So here, in recurrent infections, suppressive doses till the delivery. Apart from this, like uh, if the preterm in the recurrent herpes, if the PPROM occurs before 30 weeks, 34 weeks, even the conservative expectant or the conservative management can be done, and the prophylactic steroid for the risk of preterm. Okay, so so if the pre-prom occur in in the then the patient is for like primary herpes. In that situation, they are giving steroid, intravenous acyclovir till delivery, and cesarean section birth. But if it occurs recurrent, then antiviral suppression, conservative management if it is less than 34 weeks, and the steroids. Now, what could be the symptoms for neonatal herpes? These are the symptoms. Just knowing it would be enough, like poor feeding, lethargy, vesicles. Skin vesicle can present in 1/3 of the babies. Fever, seizures, changes in consciousness, liver dysfunction, coagulopathy, and pneumonitis. Now, this part has been added new in the guideline. It was not there previously. So, a little knowledge about this is important. Now, they have classified the neonates into four parts: having highest risk of infection, high risk of infection, low risk of infection and the lowest risk. So now coming to the highest risk, who are the babies who are at the highest risk of infection? If the babies are born by vaginal birth and the mother having herpes lesion, or mother and the parent is systemically unwell with the herpes, or birthing mother or the parent have active herpes 4 weeks postnatal. So these are the three scenarios where the baby would be at highest risk. I'm repeating it again. Highest risk baby, when the baby born with a vaginal birth in the presence of active lesions, when the birthing mother is systemically unwell with a diagnosis of possible HSV, when the mother have active primary lesion or parent within 4 weeks postnatal. These are high risk baby. Urgent. So how would be the management? Urgently information to the neonatal team, urgent assessment of the baby, and like uh, HSV PCR swabs are taken, bloods are taken for full blood count, LFT coagulation profile. Apart from this, how would be lumbar puncture can be done for these babies. Apart from this management, the dose is the same, 20 milligram per kilogram of body weight. And if all they could be given, like when the all results are negative, then it could be given for 10 days. If the skin eye mouth disease, then it could be given 14 days. CNS or disseminated disease, it is given 21 days. And once the oral prophylaxis is done, then they would be once the IV is completed in the disseminated post IV therapy, when the patient has got CNS or disseminated disease, then they would consider oral prophylaxis for 6 months. And these are the warning signs given to the parents. So this is the management for the highest risk baby. Now second type of baby is the high risk. Though now the babies are born n- like without any lesion, but yeah, they are born within the six weeks of infection. So there was like protective antibodies are not there. Or cesarean second choice or high risk babies, when the cesarean section is done rupture with rupture of membrane regardless of any duration, that time baby should be seen within 24 hours postnatally. uh, Swabs are done, bloods are done, and acyclovir is started. And usually u- usually acyclovir is started, and usually it is for 10 days. So why this less treatment? Because the problem here in high risk, the baby has got the protective antibodies were not there. Now coming to the low babies, what could be the low risk? When the lesions are there, but they are recurrent lesion, or baby is born less than 37 weeks. And so these babies are low risk baby. They would be seen 24-hour back investigations. PCR swab and the bloods are done, and treatment depending upon the results they find. And these are the babies when they are born more than 37 weeks and more than 6 weeks the mother got infection, so they have got good amount of protective maternal antibodies. So usually only information of neonatal team is done. Baby normal postnatal review will be done at 24 hours. No investigation, nothing is required. Okay. These identities of classification of neonates has been added in this new guideline. It was not there previously. So part 2 people, it becomes important because they can give a scenario that baby is at high risk, highest risk, how to manage. So part 2 people has to learn it clearly. Part 3 people not that important. No, the like this is important. Efforts are taken to prevent postnatal transmission. So they should be hand washing. Baby should not be kissed by other people other than the close family member. Kissing on top of head would be is permissible, but kissing baby near nose, mouth, and eyes to avoid any mucous membrane should not be there. Patients or people having cold sore should not kiss the baby, and like the people having active lesion at any site, they should avoid touching the baby, and like they should have a good hand hygiene. So it is not that important. Basically, good hand hygiene and avoiding exposure to the baby is important. Okay, this was also important. It was not there in previous guideline. Now, if the uh, like if the breast lesions are there, so the uh, feeding should not be done from the affected breast, so that the baby would not touch the breast. Even from the affected breast milk should not be used. Apart from this, this is a new thing that has been in this guideline. If there had been first episode of herpes on breast or recurrent breast lesion, and the patient is breastfeeding, then suppressive doses of antiviral should be given until baby reaches 6 months or whichever longer. Second, if there is a history of breast ulcers but there is no recurrence, that time suppressive antivirals to be taken till 6 weeks of life. So this suppressive antivirals, though the guideline mentions it, but they also say that the too much evidence to support this kind of treatment is not there. But yeah, you should know it as an update. Now, this also added in this guideline, that is a clinically discordant couple. It is very clear from the terminology that the woman has got no previous HSV, herpes simplex infection or ulceration, and the sexual partner have previous diagnosis of genital herpes. So, like these are the clinically discordant couples. So, what really they has to do? They had to avoid guideline recommends any kind of sexual activities, oral, anal, vaginal, in last third month, third trimester, even 2 weeks prior to that, because this would be the most effective way to reduce transmission risk and recommended to all couples. But if going for an abstinence is unacceptable to the couple, then a male condom should be used consistently. Apart from this, consideration for antiviral suppression from the for the sexual partners can be done. So that will suppress the symptoms or asymptomatic viral shedding to reduce risk. So this is again in the new identity that has been added in the guideline. Apart from this, mother and the pregnant woman without orolabial herpes advised to abstain from the oral sex in third trimester and 2 weeks prior to that, because to reduce risk of HSV again. So this is the kind of management for the discordant couple that the guidelines suggest. So, any question any people have till now? Okay, no question. Fine. So this is the summary chart from the guideline. If the primary herpes happens in first and second trimester, then standard doses are given, and patient would be given a suppressive dose from 32 weeks of pregnancy. Those at a risk of preterm will be start with suppressive dose from 22 weeks. Okay. If it is a recurrent, then standard doses or treatment is done, and the suppressive doses are given as like that. If the primary herpes happens within last happens in third trimester, then treatment as usual and suppressive doses. Apart from this, delivery by cesarean section. Okay, that's all I had to say. If any one of you have any question, can ask. Otherwise, there are few questions that I have put. Any question? No. Okay, so only three, four, not too much of question, 4, 5 questions only. So 25-year-old woman with 24 weeks with recurrent herpes. Episode was 6 months ago. Treated with acyclovir. When examined, she has no lesions on vulva. Screening for STI negative. So what should be the management for this woman? So history of recurrent herpes, what you will do? So you have to start. Anyone can speak. What you have to do? You have to start suppressive dose. Suppressive dose answer is D from 36 weeks. But the question is from previous guideline. New guideline acyclovir suppressive doses from 32 weeks of pregnancy.
Yes, ma'am.
Yeah. So this is the same thing I have already spoken. So 20-year-old woman with 39 weeks, painful ulcers. These are the herpes on examination, 6 centimeter dilated. PCR has been sent, cesarean section has been discussed. She wants a vaginal birth. So what you will do? So patient with active lesions wanted vaginal birth. What you will do?
Ma'am, N, ma'am.
Yeah?
N, ma'am. Intravenous acyclovir to the
Yes.
mother. 5
Yes.
milligram per kg.
Here you have to give IV acyclovir to mom and to also
Hmm.
the baby. Yeah, very
Baby. Hmm. Hmm.
okay. So 21-year-old woman, 33 weeks of with the leaking of waters. So PP like pre-rupture of membrane. As speculum vulval blisters are found. Even the pool of fluid can be seen. Now the PPRM diagnosis is made and PCR confirmed herpes virus. This is her first episode. So primary episode at 33 weeks.
Ma'am, you have to give G, ma'am. Corticosteroids and IV acyclovir 5 milligram
Yeah, so
per
answer
kg.
should,
Hmm.
answer should be G.
Hmm.
Hmm?
Yes,
Yes,
ma'am.
answer is G. Very nice. So 32-year-old woman with active lesions attends for the discussion of prolonged management at 41 weeks. She has 41 weeks and she has active primary lesions. So what is the mode of delivery?
C,
Cesarean.
section. Hmm.
Cesarean. 22-year-old woman with 32 weeks recurrence. Now it is a recurrence virus. What is your advice with the plan of delivery?
You have normal delivery, ma'am.
Yes, normal delivery and according to new guideline 32 weeks
Hmm. Suppressive dose.
suppressive dose. This question is from the previous guideline, because of that they wrote
Hmm.
it 36 weeks.
Hmm.
Okay, 26-year-old woman with preterm labor at 36 weeks, and she has been history of chlamydia treated 3 years back. Now she started with acute dysuria 2 days back, which is not improved. So what is the diagnosis? So patient
Hmm.
presented with a dysuria, not improved on the treatment,
HSV, ma'am.
HSV. So she's having dysuria, and they're misdiagnosed as UTI, and they're treating it on the antibiotics. Okay, that's all for the new updates about the new guideline. Thanks for joining. Any
Thank
question?
you, ma'am.
Any question? Okay, people. Thanks for joining. Bye.
Thank you, ma'am.